So, Dr. Coyle, have the use of disease-modifying therapies altered the long-term course of multiple sclerosis?
So this is a very good question, and this is how you have to think about it. MS is for the long haul. So when you're looking at disability, for example, the average time to move from a relapsing to a progressive phase, secondary progressive, is about 20 years. So you really probably need to look at a large population for 2 to 3 decades to get an accurate handle on whether you're changing the natural history of a disabling disease. And frankly, the very first DMT only came out 20 years ago, and its use was not immediate, et cetera, and it took about a decade. We are seeing preliminary studies, early studies, that suggest, for example, that the transition from relapsing to secondary progressive disease, and remember, when we say somebody becomes progressive, they're going to become disabled, 100% guarantee, is significantly less in the treatment era or with treatment compared to historical controls or compared to simultaneous controls that were not treated. And not every study has shown this, but I would say the bulk are giving us optimism that we are meaningfully impacting to change for the better the natural history of MS. And certainly any of us who took care of MS in the pre-treatment era and post would say we aren't seeing patients come in wheelchairs, we're not seeing have them devastating attacks, patients are doing much better. You can have patients walking around with MS. You would never suspect they have any neurological disease whatsoever. They look fine, and they've been on treatment 10 years and 12 years, and they are doing great. My own belief is that we are definitely changing the natural history, but I think we're going to need probably another 10, 15 years of data to really prove that.
You know, I'm really glad to hear you say that, because one of the things from the payer's side is the fact that we don't have that data or haven't been able to see that data. In fact, we were speaking about this prior or earlier today, and the fact that the studies that are right now out there on all the therapies, they were done at different times, they were done on different populations, we treat much earlier. The earlier medications were done on patients with more severe,
Absolutely.
or they were more, they were had for a longer duration. So we have the hardest time really looking to see what is being done, you know, how well that therapy is working. And again, because it's such a long-term disease for so many people, and the gathering of the data is just so hard that when we look at it, we see the decrease in the attacks, but we really can't see, did it, you know, lengthen the period again that they needed to have home health care? Did it lengthen the period, the duration until they're institutionalized? You know, what did it really do? And because of that, there's whole sorts of issues, but what is it doing? We have a hard time actually comparing the relative benefit between the products. And
Virtually all the studies, and you can critique them, but virtually all the studies have indicated that earlier treatment in the long term does better than when you have a delay of treatment. And I personally believe that the optimum time to treat MS is very early, at the first attack or shortly thereafter. I think that concept of a window of opportunity where you can control the damage process. And remember, we're learning this from rheumatoid arthritis and Crohn's disease and systemic lupus, which are immune-mediated organ-specific diseases akin to MS, where really treatment and control of the disease in the first couple of years is key, and you need to escalate up to get that. I think that's the philosophical approach that most of us have been taking, and I think we will ultimately get the data to document that. But certainly all the hints, the clues are there. Wouldn't you agree with that?
So I would, and I share the same belief that you do, that we're making a difference, but you guys don't care about my beliefs. However, there are some data that are worth noting. One is that lessening attacks themselves have a benefit. There have been multiple studies now that have shown that 50% of attacks leave residual deficit, something. And it could be mild, it could be severe. It could be blindness, it could be a limp, it could be unable to move one side, 50%. So just cutting down on the number of exacerbations, which is our clearest signal in our clinical trials, has a clinical benefit. In terms of changes in disability, most of our studies have shown statistical difference in changes in disability, but in the early phase of the disease. In the later phase of the disease, we've not. The progressive phases, we have no therapy that we've satisfactorily proven to be of value, but we're moving in the right direction. When you get to the studies looking at transitioning into secondary progressive disease, you get into some very, the nicest word I can use for it is arcane statistical manipulation, where you're trying to make up for the lack of a control group to compare your population with something, whether you treat it, and most often they're compared with either natural history or with patients who are untreated. Both are terrible comparator groups, because if someone's not treated, there's a reason why they're not treated. So that's a bias in the sample right there. And natural history is just not the same as the unnatural history that we see during clinical trials, and the data are not collected with the same kind of rigor. That said, Dr. Coyle points out to a couple studies that show that using statistical inferences to try and get beyond the biases of those groups, that there looks to be a benefit of the agents like interferon in lessening the number to go on to secondary progressive disease. And then there's a third study which suggested just the opposite. And I would suggest they're all flawed, and that the assumptions that are drawn for them are all up for question, because there are no good methods for looking at that. Perhaps the study that I find most compelling in that regard is a study looking at mortality of individuals who are on interferon beta 1b. And this one, I didn't like the study when they first proposed it and was extremely skeptical of the outcome, but I've looked at the data and it's actually very well done. They looked at mortality, which you guys will all agree is a hard outcome. We don't have to define it, we know it when we see it, right? And so they looked at mortality in individuals who in the first trial, what Dr. Coyle referred to, the initial interferon beta 1b pivotal trial that was reported out in 1993. And in that trial, individuals were either on a high dose or a low dose of interferon or placebo. Patients were on placebo for up to 3 years. They went and they looked up that cohort 20 years later and looked at their mortality, and they had a very good accrual of getting the mortality. You have to bring the patient in for exams or anything like that. It's, again, a hard outcome. And there was a difference. There was a statistically significant difference between the individuals who had been on interferon just those initial 3 years, 20 years later. I was very surprised at this outcome. But and when I've looked at it carefully, and when they went and looked at the causes of death were primarily related to MS.